Well, first of all, I would like to thank the organizers for being here and talk about one of the most neglected issues in the global management of cancer patients, because we've seen that clean pain control and psychosocial support is included, at least in the national cancer plans, but nutrition is completely neglected. That's why I already approached Dr. Albrecht to see if we can do something for nutrition for these patients. So just a few words on what is ESPEN. ESPEN is the European Society for Clinical Nutrition and Metabolism. It's a multidisciplinary, I just added multi-professional scientific society whose aims, of course, are fostering research, improve education, enhance clinical practice in clinical nutrition and metabolism. It's really a global society. It's a European society, but in the ESPEN Council we have society from all over the world. We have from the US, Brazil, India, Japan, so all over the world are represented in our society. We have our website, which is at www.espen.org, and our activities are really organized through Congress, educational courses, and we have two journals, Clinical Nutrition and ESPEN, which is an only electronic journal. But let's go now to the focus of my short presentation. So if you look at the figures, okay, you see that for some cancer over the last 10 years, the prevalence has reduced. The relative risk of cancer death for being diagnosed 1 year later has improved. So it appears that maybe something is really going good. But if you look at the worst, at the problems, you see that, for example, the costs for cancer care is rapidly increasing. And these are the data just published in Journal of National Cancer Institute in January, showing, for example, for a single cancer patient with pancreatic cancer, well, it costs $150,000 US per year. And even in the last year of life, if he dies of cancer, it costs $164,000 US. So I mean, the costs are enormous. Should we cut this cost? Of course not. Should we give better care for this amount of money? I think so. And the other big problem I see in the optimal management of cancer patients is the problem of malnutrition. Malnutrition is not a word. Malnutrition is not a philosophical terms. This is malnutrition. And we see malnutrition every day in our hospitals. This is a patient with advanced pancreatic cancer. And one would wonder why this patient has become so malnourished. And with a patient so malnourished, of course, the complications increases, and probably he cannot even sustain any kind of therapeutic approach. But the quality of life of this patient will be miserable. And this is a patient which is frequently seen in our hospitals. And indeed, if you look at the literature, you will see that actually having a good nutritional status has a significant impact on survival of these patients. These are just some data showing the survival of patients, for example, with gastric or esophageal gastric junction tumor. Well, those with no weight loss has a longer survival. And more importantly, Paula Rabasco from Lisbon, from Portugal, has clearly shown that patients with a good nutritional status can really improve their quality of life. And this is just another data about the fact that survival in patients with small cell lung cancer without weight loss has a longer survival. So I think that the evidence is there. More importantly, this is another quite recent study on ovarian cancer, showing that if you have a patient who is malnourished, and then you are able, because of your nutritional intervention, to improve his malnutrition, his well-nutritional status, well, as you can see, the survival of these patients is improved. So I'm not saying, I want to be clear on that, I'm not saying that we are curing cancer with the food. We are not curing cancer with nutrients. I'm just saying that we can help our patients to complete, for example, the radiochemotherapy dose. They can undergo extensive surgery so they can another chance to survive to their cancer. And this evidence is there, and oncologists know that. This is a nice survey done a few years ago showing that 91% of the oncologists actually agree on the fact that nutrition can have a significant effect, for example, on the morbidity of cancer patients. But still, if you look at what happens in the daily practice, you see patients severely malnourished. This is actually a patient not with cancer cachexia, but with HIV cachexia. So interestingly, in the same survey done 5 years ago, there was asked what barriers prevent inclusion of nutrition on oncologist patient care. And as you can see, the vast majority of these oncologists were saying, we don't have clear guidelines. Not meaning we don't have guidelines. We don't have clear guidelines, meaning that probably we have so many guidelines, and so really you don't know how to deal with all these information in the clinical practice. So another important aspect is the fact that right in these days, I was amazed by this paper, editorial published in Nature Medicine, which we can say has no bias against, well, toward nutrition. Well, actually, also the nutritional, well, the drug approach should be reconsidered. And so I'm pretty sure that if we have to develop during this partnership the best oncological approach to cancer patients, well, I think it should be on the multimodal therapy. And of course, and I would like to underline the fact that the best treatment is, of course, the optimal oncological management. No doubt about that. But of course, it's also the best supportive care, psychosocial support, pain control, but also, for example, early intervention, the multidisciplinary and multi-professional teamwork, the awareness, for example, the exercise and nutritional support. So I think that really could have an impact, a significant impact on the outcome of these patients. And so what we are like to do, in the first phase 1, we would like to develop some new clinical guidelines. And as you know, developing clinical guidelines is quite easy. You have a panel of experts, you agree on those clinical relevant questions to be addressed, you have a systematic review of the evidence, and of course we are here not to reinvent the wheel. And if good clinical guidelines are already available, just say, this is the best way to approach this clinical question. No need to really reinvent the wheel. So we have to weigh the evidence, and then you can have a consensus on recommendations. Of course, the most complicated part would be on the implementation of guidelines. So we plan to spread via scientific publication, but you know very well that if you want that something is not really done in the clinical practice, don't publish in the scientific journals. It has been clearly demonstrated that people, actually doctors, not really involved in scientific research are very unlikely to change their clinical practice because you published a paper on New England Journal of Medicine, on Science, or Nature. So we need, of course, to collaborate with the other partners in this partnership. We would try to involve media just to let the people, let the cancer patients aware that there is a problem and they have to ask for the solution of this problem by their doctors. And I think that there are some, for example, some data interesting. For example, this is a quite recent paper, not really published in print actually on the paper, but is available electronically, showing that, for example, in patients with lung cancer, you provide the best standard of care or the best standard of care and some kind of nutrients, so you also take care of the environment in which these cancer cells are growing, you can have a significant increase in the response rate of these patients. So again, I'm not saying we are curing cancer with nutrients or with food, we're just trying to give more opportunities to the patients. And I would like really to conclude with the feeling that I had from early March when I attended the kickoff meeting in Dublin, and after this morning discussion, I really think that we can really do something. And I feel like Howard Carter, probably most of you know Howard Carter. I think he had the most extraordinary experience that anyone can have, because you can win a Nobel Prize, but next year there will be another one. And in 2 years' time there is other Nobel Prize. But Howard Carter was the first, and so far the only, who discovered and not violated tomb of an Egyptian king, Tutankhamun tomb. And if you look at the writings of Howard Carter, it's amazing, because on November 27, 1922, he was in front of the last wall, which was in front of him and was preventing him to go to the tomb. And as you can see, he made a hole in this wall, and he tried to look at what was behind the hole, and he saw something, glittering, something sparkling, and he thought, well, this could be a treasure, but of course, it could have been also fake gold. But then the story proved that it was sure, it was right, and it was gold. So I'm pretty sure that during these first months of this partnership, we are like Howard Carter there. We are looking what we can do. We see something. We hope that in 2 years, 3 years' time, we can find gold. Thank you very much for your attention.